Okay, so we get started. So Dr. Lee today, presenting his Journal Club. We have two very interesting articles to talk about. So,
Great. So my faculty discussant is Dr. Schiano. He'll be here shortly. He's on service. I think he's just finishing up rounding. So these two articles we selected. I have sort of an interest in both auto and alloimmunity, and so we'll start with first is the autoimmune article, published in one of our higher impact factor journals in CGH, and it's titled Rapid Response to Treatment of Autoimmune Hepatitis, which I'll just refer to as AIH by its acronym, throughout this presentation, associated with remission at 6 and 12 months. This was a multi-center study out of Europe. So, introduction. So autoimmune hepatitis is one of the several autoimmune liver diseases. It's characterized by elevated transaminases, a high serum IgG, seropositive autoantibodies with anti-nuclear antibodies, smooth muscle, LKM, and on biopsy it shows a lot of inflammation. The initial treatment is usually with corticosteroids, and eventually you'll transition to maintenance azathioprine. And we define biochemical remission as normalization of liver enzymes along with IgG, which has sort of become the new trend in treating autoimmune hepatitis. Patients, so a couple studies previously have shown that patients with AST levels greater than 10 times the upper limit of normal at baseline have lower risk of cirrhosis and better long-term outcome. And in addition, patients who do not achieve 50% of decrease in their liver tests at 6 months usually have to get referred and end up getting transplanted. So the aim of this study, and there was never really a study looking at the dynamics of liver enzymes and their relationship to the outcomes of these patients, was to look at patients with rapid decreases in their transaminases and whether they have a higher probability to achieve remission and lower risk for overall outcomes. Liver-related outcomes. It was a retrospective study across 12 centers in 7 countries in Europe. They had 2 cohorts, so what they did was they collected everybody and then they randomized it to a discovery cohort where they found some findings and then they validated their findings with a separate cohort. This was all randomized apparently. They were all adults. Diagnosis of autoimmune hepatitis was defined by the simplified IAIHG, which is one of our international autoimmune hepatitis groups and their guidelines. And if you didn't meet the simplified criteria, then you would have to meet the revised criteria with a score like greater than 10 or so. It excluded all variant syndromes with other autoimmune liver diseases such as primary biliary cholangitis, primary sclerosing cholangitis, or any other liver diseases as well. Outcomes were normalization at 26 and 52 weeks, so basically at half a year or a year of treatments, and they looked at liver-related mortality, liver transplant, all-cause mortality, and HCC as well. So the way they defined if you were a rapid responder was they ran a receiver-operator characteristic curve analysis, and they performed cutoff analysis using a Youden index, which really sort of captures the best level where you have the most optimal sensitivity and specificity. And they did that at 8 weeks to see exactly how much % decrease in transaminases is considered a rapid response. So looking at the baseline sort of characteristics, there were about 370 patients in each cohort, and they were pretty similar other than age. The validation cohort may have been just a little bit older at 50 years versus 47 years. So otherwise pretty similar. The cutoff was classified at around 80%. So if you had greater than 80% decrease at 8 weeks, you were considered a rapid responder. So they then performed their analysis in the discovery cohort. So the discovery cohort showed that there were about 61% of patients, the 370 patients who were rapid responders. These patients had higher liver enzymes and bilirubin at baseline. They were less likely to be cirrhotic. And they also had, they're more likely to have what they called acute severe autoimmune hepatitis. And this is just if you had a INR greater than 1.5 without cirrhosis. They did exclude all patients with acute liver failure as well in this study. These patients also were notably having higher prednisolone dosages. So that's something to keep in mind as we go through the study. So they then sort of performed these outcomes with both discovery and validation. So To your left is the discovery cohort results, and to the right is the validation cohort results. So I'm just going to show like a side-by-side comparison. And really, it showed that the patients who had rapid response, which is the right column of each side, showed that there certainly were a higher association with normal transaminases by 52 weeks, at both 26 weeks and 52 weeks, basically. In addition, it also showed that these patients had higher risk of liver-related death or liver transplant as the ultimate outcome. In the discovery cohort, they also noticed that these patients who had rapid response were, sorry, I said more likely, less likely to have liver-related death or liver transplant. In addition, in the discovery cohort, they noted that patients who rapidly responded were less likely to have all-cause mortality and less likely to develop HCC as well. These findings were not found in the validation cohort. I think there were just no patients with HCC in the validation cohort. So, one thing to note again is the prednisolone dosages. So the patients who had rapid response were actually on sort of higher doses of prednisolone at around 26 weeks. This also is a Kaplan-Meier curve. The y-axis is looking at liver-related death or liver transplant, and the sort of the slash lines or the sort of the scattered line plot are patients who were slow responders, so they were more likely to have liver-related death or liver transplant. So this is all at 8 weeks. If you didn't respond well in 8 weeks, your risk of death or transplant was much higher. Again, sort of looking at discovery and validation, this time they ran a Cox regression analysis for survival analysis. They found, again, the similar results in the discovery cohort. These patients had a lower hazard ratio if you were a rapid responder compared to a slow responder. These findings weren't found in the validation cohort, and it may just be related to sort of sample size. So this is sort of what I thought was very interesting in the study was, okay, so we know that rapid responders do very well. What about slow responders? How can we parse this subgroup of patients out and know that if they can do, if they're ultimately going to do okay or not? So what they found that they looked at those patients who didn't have that 80% decrease at week 8, and they did a separate analysis of these patients. And what they found that in these patients who achieved normal transaminases by 1 year, their rates of, their numbers, number one, were much better at baseline, and also they had they were less likely to have liver-related morbidities or liver transplant as well. So even if you were a slow responder, the fact that if you don't achieve normalization by 1 year, your risk of death or transplant is much higher.
Ryan, what was the follow-up? Did they have death or LP within 52 weeks?
Yeah, within those 52 weeks, yeah.
So this is normal transaminase at week 52, but then their transaminases are still like 2 points.
So I think this is at baseline.
Baseline.
Yeah. So at baseline.
Oh,
Yeah. And so the bilirubin translates to, I think 36 translates to like a bilirubin of 2, just to, for American metrics. So the second sort of interesting portion I thought about this study was this whole concept of transaminase dynamics. We talk a lot about baseline liver tests and how they portend to risk, but in this study, the novelty is that regardless of your baseline AST, if you responded rapidly in 8 weeks, it added predictive value. So even if it was high, or say it was medium or moderately high, as long as you respond rapidly, your chances of good outcomes were much higher. So in conclusion, if you had a rapid response in greater than 80% of transaminase decrease in the first 8 weeks, your chances of normalizing and having biochemical remission at 6 months and a year were much better. And this was associated with lower risk of liver-related death or transplant, although this was really found in the discovery cohort. If you had slow treatment response at 1 year, that's when you had the highest risk of liver-related death or transplant. And this whole concept of the dynamics of transaminase changes, it's more than just looking at one number at baseline. Lower baseline transaminases in slow responders could indicate sort of a subclinical course. These patients definitely were more likely to have cirrhosis, and cirrhotics, again, are more likely to have lower transaminases. And one of the thoughts by the authors was that perhaps the rapid response really leads to immediate deactivation of stellate cell activity and the development of fibrosis, which ultimately results in the morbidity of our patients who have autoimmune hepatitis. Because of the importance of cirrhosis and outcomes, they did both subgroup analysis as well, which I didn't show, but of cirrhotics, and they showed similar results. And they actually even excluded cirrhotics, and they found similar results as well. So cirrhosis was not a confounding variable. Some limitations of this study: it was retrospective, and there certainly could have been a selection bias. They really picked patients who had enzymes within the first 8 weeks. But it was a large cohort, and it was a real-world practice where they collected real data. Rapid responders did have higher steroid dosing, which may have played a role. They did comment on that. Normalization of transaminases versus biochemical remission. A lot of times we look at AST and ALT as the final outcome, but newer data has been showing that, along with that, following the IgG activity is very important to understand if a patient has adequate response to their treatment of autoimmune hepatitis. The one other thing is the lack of histology at diagnosis or follow-up in terms of the data on that. There has been data previously, I think, many years ago, sort of in the early studies for autoimmune hepatitis, where we know that the level of ALT may not actually correlate with how much severe interface activity that the patient may have, or fibrosis. So it would have been nice to have that data included in the study. None of this applies to patients with acute liver failure, and they also decided to include patients who had this acute severe autoimmune hepatitis who may have a different phenotype as well. And so that's this study. Are there any questions or comments? I think it was a pretty good study. It had a lot of clinical application in at least the slow responders and understanding, who are at higher risk, who needs closer observation, maybe early referral for liver transplant as well.
One thing that I just thought about is that in NASH and Hep C, transaminases really don't correspond very well to disease activity, modestly, but they're not really sensitive and that specific. And yet here, it looks like, or one can presume, that the transaminases are quite indicative of the amount of liver damage. Are you familiar, or maybe Joe or Tom, have there been any studies that actually correlated AST and ALT and autoimmune to the extent of histologic damage?
There have been some older studies. I know I've read sort of one or two that looked at the actual ALT level and sort of the actual degree of interface hepatitis a patient may have. And there wasn't a significant correlation in some of those studies. But then there's other studies that do show that as well. So, but I know there have been studies showing that they don't necessarily correlate. Sort of like sometimes how we see in post-transplant patients who have rejection. So
I think to answer your question, every time you have high AST level, you have still high inflammation, but when they are normalized, you could have normal inflammation or still little inflammation. So it's not a good negative predictive value, but it's a good positive predictive value. And studies have shown that you can refer to the transaminases if they are completely normal, and also the IgG. You can stop the treatment without doing a biopsy.
Sure.
One of the biggest factors that correlates with outcomes in autoimmune hepatitis is compliance with the medication. I didn't see anything mentioned about compliance.
So that certainly also was a limitation where they didn't report on that data as well.
Probably the biggest thing in my cohort.
What about addition of like immunomodulator, like azathioprine?
I think they adjusted for baseline immunosuppression in their regression analysis, and that didn't seem to be a significant factor. And one thing to your comment, Dr. Friedman, I don't know, if, maybe someone in the audience knows, if there have been any studies on IgG activity and sort of histologic activity, if there's any correlation with that. I think that would be rather interesting as well, because if the serum IgG is a reflection of the plasma cell IgG inside the actual liver, and if that's a sign of active inflammation, then it may have some correlation, but I don't think there have been any studies on that. So.
I don't think there's a histological scoring system. as quantitative for autoimmune hepatitis. So it's hard to do these correlations with the enzyme levels.
Did they exclude people who might have had like a drug-induced autoimmune hepatitis? Or did they kind of lump everyone in because you could imagine
Right.
those people would maybe have better response?
Yeah, I didn't see anything specifically written about drug-induced. I'll have to double check, but I don't remember seeing that at all.
Just small fraction.
Brian, sorry, I walked in a little late. You
Yes.
probably covered this at the beginning. What was their protocol for prednisolone dosing?
So it was variable on sort of each practitioner, but what they just did was they collected what dose the patient was at like 26, etc., and then just sort of compared that as well. So
So based on these results, what would you suggest as an appropriate starting dose? Do you think
Right.
prednisolone is better than prednisone?
right. So great questions. So one of the issues for people who may not be aware in the audience is that the conversion of prednisone to prednisolone happens in the liver, and the thought is if you have severe liver injury that you're, that conversion may not be going well. I don't know. I mean, maybe other people have opinions, but it doesn't seem to be a big difference in terms of its effect. They did say that patients in this cohort were both on prednisolone or prednisone. They didn't really show any data on whether there was a difference in which type of treatment you got. In terms of initial dosages, I don't know. I've always been trained to go heavy in the beginning with 60 and then just bring it down. But some people go with 40 and ultimately putting them on maintenance when they're not jaundiced is sort of a thing. But I think one of the important caveats is also just really treating to the IgG level along with transaminases. I think that's really important because I think there have been studies that show that the serum IgG certainly can correlate with relapse and sort of disease activity in that aspect. But I don't know if anyone else has any opinions on doses. Yes, Dr. Kim.
I mean, you never want to make any generalization based upon your own clinical opinion. Going back to what Scott said, I have a handful of patients with autoimmune that were diagnosed on biopsy, treated, and completely single-digit ALT/AST, and 10 years later, they're cirrhotic. So who are these people? I have no idea. But
Right.
we've seen it both in non-transplant and post-transplant.
Right.
Where, 10, 15 years later, again, with persistently normal ALT/AST, they get progressive cirrhosis. Without any other cause. It's not like a concomitant NASH or anything else. So just an observation.
Yeah.
Yeah, it's important, and I was actually going to ask what was, since this is retrospective, presumably they can find some of these patients, do they have any long-term outcomes to show that the rapid response is
They didn't speak about sort of long-term response after. I don't think they did. I don't remember if you saw that, Dr. Stiano, but I didn't see anything on past 52 weeks.
Did they not? Did they just not report on the biopsies, or was it the general practice they didn't do biopsies?
I think patients at least had a biopsy at the time of diagnosis.
They should have, because they follow the recommendation of international guidelines.
Right.
So they should have
So they went by that criteria, but they didn't specifically talk about sort of histologic activity at all. Which I think they even mentioned just in their limitations was that because of maybe it was the complexity of having 12 centers and different pathologists, but they didn't speak specifically about looking at the histologic activity, which they knew was sort of very important. But
Is it statistically valid to come up with a validation group that way, just by randomizing your groups?
so that was, I think, also an issue with the study is that they sort of just randomized themselves without, it wasn't like a prospective study where they placed a person in a discovery arm and in the validation arm and then followed them through. They just sort of had 740 patients. Somehow it was perfectly even amongst the discovery and validation, and then they just followed them. So, all right. So that was that study. This next study is a bit more technically complex, but also very interesting. It looks at immunosuppression withdrawal in liver transplant recipients on sirolimus. and it was reported primarily at Northwestern, but I think several immunologists from other centers were involved. So the mechanisms for T-cell immunosuppression, we're getting more and more creative. Calcineurin inhibitors remain the primary agent for use, but we've sort of started to also play around with mTOR inhibitors, with sirolimus, and recently everolimus as well. And sirolimus and everolimus are both mTOR inhibitors. They work sort of at the actual site of the nucleus in stopping the cell cycle proliferation, versus calcineurin inhibitors, where they sort of respond right where IL-2 is produced. So calcineurin inhibitors are excellent, but they do carry some long-term risks, and there's been a lot of research now sort of looking at toxicities of immunosuppression and are patients able to withdraw from immunosuppression. To sort of counteract this issue with calcineurin inhibitor toxicity, we've started to play around more with mTOR inhibitors and immunosuppression, where we convert them or use a combo to stabilize the GFR and actually still have low risk of rejection. There have been many studies on this, or several studies, not many. mTOR inhibitors theoretically are thought to promote an immunoregulatory state. And the thought is that because how they, where they play with, where they interact with the T-cell activity different from calcineurin inhibitors, there may be an increase in the effect on sort of regulatory T cells and dendritic cells as well. And there have been a lot of in vitro studies by this group where they showed that dendritic cells can induce anergy of actual T cells and ultimately create this regulation of T cell activity. So one of the sort of popular terms now is operational tolerance. So it looks at each patient and says how little immunosuppression do they need where their allograft will be functioning perfectly fine. So the hypothesis of this group was they used sirolimus to promote immunoregulatory pathways that allow for immunosuppression withdrawal. And they did this in a very nice sort of translational approach, where they first did their primary outcomes were looking at sort of a clinical, sort of what we do, where we look at liver tests and biopsies to make sure that the patient's not rejecting. But they also looked specifically at PBMC profiles, and they looked at, they did some secondary analysis with immunohistochemistry of T cells in the allograft, along with gene expression patterns. And a lot of this, I think, is promoted by Dr. Levitsky, who's created this sort of gene expression profile where he can predict patients who can reject or not. So I think they're trying to validate its use in the future. So this was a prospective trial. It was a single-arm study with patients on monotherapy with sirolimus and stable liver transplant recipients. So all patients were from Northwestern from 95 to 2012, all adults. They had to have been more than 3 months of sirolimus monotherapy and at least 3 years out from transplant, whether it was from a living donor or a deceased donor. Exclusions were anyone within a year of enrollment who had abnormal liver tests from anything or T-cell mediated rejection, if they had viral or autoimmune etiologies of liver disease as well, if they've ever been retransplanted, if they had HIV, if they had bad renal failure, or they just couldn't consent. If also what happened as a part of this protocol was they all received baseline biopsies. So if their liver tests were normal, but the baseline biopsies showed any signs of inflammation or fibrosis, they were also excluded. And also sort of quote unquote what they called high risk pathology, and they sort of left that up to the pathologist to decide. So this is sort of a timeline of how they performed the withdrawal. So the top looks particularly during the withdrawal phase, and then the bottom will sort of follow through with how they surveyed these patients. So they initially would reduce the sirolimus by 50% of its total dose, ultimately where you came down to 0.5 milligrams a day for a month. From there, about, I think every month they would reduce you to like every other day, then twice weekly, and then once weekly. And then if your liver tests were normal after a month of being on once weekly sirolimus, then they completely stopped it and followed you. So this whole process took about 3 to 6 months for the patients. After that, they followed these patients for an additional, I think, 12, 16 months with physical exams. They did frequent labs. anytime you had an abnormal liver test, and they did this every 2 weeks in terms of the lab tests. Anytime you had abnormal liver tests, you were immediately biopsied to see what's going on. So the primary outcome was normal biochemistries and graft histology at 12 months. Secondary outcomes were looking at rejection, resolution of sirolimus-associated side effects, and the assessment of tolerance biomarkers. So they had a total of 15 patients who underwent weaning, and eight patients were successful at the end of the study, and 7 were not. There were no differences at baseline in between these two groups, how long they were on sirolimus or a time from transplant to weaning. They were very similar. In the 8 tolerant patients, there was one who at 6 months had abnormal liver tests. They biopsied this patient. The biopsy showed NASH, and actually they said that the tests completely resolved back to normal after they advised some weight loss and the patient lost some weight. All 8 had biopsies at 12 months, and that was all negative for any signs of rejection. And they do comment that the patients had minimal inflammation/fibrosis. I wasn't sure exactly what that meant. In the non-tolerant patients, there were 7 patients. 3 of them had abnormal liver tests during the weaning, and they all got biopsies that showed rejection. 3 of them had normal tests at 12 months, but then they had biopsies as a part of the protocol for the end of the study, and that showed rejection despite having normal tests. And there was a patient who had developed metastatic HCC to his adrenal gland, and he was withdrawn from the study because he was sort of resumed on sirolimus. But he was considered non-tolerant. So this figure looks at some of the PBMC studies that they were doing, and so this, on the y-axis, it's sort of a long name, but it's basically a tolerogenic dendritic cells, and so dendritic cells in the liver are thought to really assist with sort of the immunoregulation of transplant recipients. And it noted that there were much higher dendritic cells both at baseline and at the end of study in patients who were tolerant versus non-tolerant. And they also showed that at the end of study that patients who were non-tolerant had more B regulatory cells. They performed further flow cytometry, and they showed that there were lower CD8 T cells at baseline and at the end of study in patients who were tolerant, but higher TEMRA is like a T effector memory subset cell. So a lot of these other complex other complex sub T cells or subclasses of T cells. But basically what the overall picture is depicting is that these findings are suggestive that patients who were tolerant had maybe previous activation and differentiation of their T cells. They looked at DSAs as well in these patients who are tolerant versus non-tolerant. For those that aren't aware, DSAs play a role a lot with transplant, and particularly with, I'm not sure what's going on there. Particularly with antibody-mediated rejection, which is starting to become quite popular in the liver transplant literature. So they checked DSA before the last dose of immunosuppression and at the termination of withdrawal. And they showed that there wasn't really much of a correlation with DSA intolerance. Some patients developed de novo DSAs. There were patients that seemed to had preformed DSAs. There were patients who were completely DSA negative. And there was no correlation at all with whether or not you were tolerant or non-tolerant. And some of these DSAs, I mean, we're talking about greater than 20,000 MFI, so kind of interesting. Lastly, and this is a bit complex for me, but I'm going to show it, is they did immunohistochemistry, and they stained these special T cells in the actual allografts. And so if the left column looks at tolerant patients and the right column looks at non-tolerant, the brighter it is, that means the more of that cell that they have. And so they really showed that these patients had more CD3, CD4 T cell, CD8 T cell staining from at the end of study compared to baseline in non-tolerant patients, and sort of all just saying that there was more patients who were non-tolerant. And lastly, they did report on their gene expression profile of their baseline biopsies, and they apparently were able to predict the tolerance, whether you were going to tolerate or not tolerate sirolimus withdrawal in 12 of 14 patients. So just to get into the discussion of this article, I think it's still a bit early to really say whether this is a successful study or not, and what are the true risks and benefits of immunosuppression withdrawal, as we sort of speak more about allograft health and also overall recipient health in the transplant community. But this is the first study to really evaluate withdrawal from mTOR inhibitors. The thought is that calcineurin inhibitors, not only do they prevent rejection, but they may also prevent tolerogenesis, or just having allograft tolerance. So this group believes that mTOR inhibitors may provide at least more benefit with tolerogenesis. In terms of the rate of successful withdrawal compared to Prograft withdrawal studies, the rates were comparable, around like 50 to 55%, but the demographics were a little bit different. The patients in calcineurin inhibitor studies were older, and they were much further out from liver transplant. They also showed that the immunohistochemistry had increased immune activation and inflammatory activity in non-tolerant patients in terms of their T-cell activity, and also that perhaps their gene expression profile can be a biomarker for future withdrawal studies. Furthermore, the detection of PBMCs were predictive of tolerance, particularly this special subtype of dendritic cells, which may carry forward in future studies looking at tolerogenesis. And they really looked at this T effector memory subset T cell and the sort of the EOMS positive T cells, which phenotypically what they've seen in vitro studies is that this can correlate to what we call T cell hyporesponsiveness. And so the thought is that when you have increases in these cell populations, that you've sort of really beaten up your T cells and exhausted them to the point where they start to tolerate the donor graft. So perhaps this is a pathway to tolerance that can be explored in future studies, and perhaps mTOR inhibitors play a big role with this pathway. And they also show that DSA doesn't really correlate much with tolerance. Limitations of this study: there was no actual control group for patients on Prograft. This was just looking at sirolimus. And the one thing they mentioned there were no functional assays. So what that means is they didn't look specifically at sort of donor PBMCs and how that affects the recipient PBMCs, et cetera, and this whole concept of hyporesponsiveness. So it was a pretty complex study, but I thought it was quite interesting looking particularly at mTOR inhibitors, as there's a lot of thought with mTOR inhibitors and its effect with tolerance, anti-fibrogenesis, and its assistance with patients who develop CKD from Prograft as well. So that's it. Any questions?
Can you just clarify, were there any living donor transplants here too?
Yeah.
Or how many percent?
They didn't specify. Oh, actually, I think in their, I'm going to look it up right now. I don't think it was that many, but I'm looking at their chart. No, they didn't specify who got living donors.
What was their final conclusion on the T-Rex?
So the thing is, so on the immunohistochemistry, they noted that this FOXP3 T cell is much higher, but their conclusion was that the actual regulatory T cell, if it's a Treg or just an effector cell, they weren't sure exactly if it's a Treg or not, but they just noted that this was something that lit up and that needs to be explored a little bit more. So they had no real conclusions on Tregs.
They didn't directly compare against CNI, but in your review of some, I don't know if you mentioned this before, but did they have the sense that this is going to lend to more tolerance, or versus just
Right.
straight CNI withdrawal? I know that was sort of their hypothesis.
Yeah, I think it's still all theorized. I mean, the whole downfall of this study, I guess, is that they didn't have the Prograft group to do similar sort of PBMC profiling and everything. But it's all theory that mTOR inhibitors would work better with immunoregulation. So
They did mention that it was monotherapy.
yes.
Did they talk anything about patients on combination with mycophenolate plus?
I don't think so. They didn't talk about that at all. It was all just monotherapy.
Here we don't usually use monotherapy, so I wonder if that makes a difference in whether you get tolerogenesis or not. do it on other people's patients, these studies.
Yes, Dr. Kim.
You know, since Barzo did his first transplant in 1963, I think very smart labs have been trying to look at how to measure tolerance, and these very smart labs have still not been able to break that holy grail.
Mhm.
We know it exists because there are people who can get off immunosuppression. If you look at the study, it's almost 50-50.
Yeah.
50%
Right.
did and 50% didn't. And it's the same if you look at the calcineurin in CNI people who try to get off immunosuppression.
Right.
I do think that we'll get there at some point in time, but nobody knows how to measure tolerance still. Nobody knows what marker there is.
Right.
I will tell you, actually, Dr. Barbara Murphy is looking at this in the kidney transplant population, and there are commercial products that are being used to try to predict rejection based upon these gene expressions. So I think we're inching closer to it, but I still actually don't think it's not going to be in my generation, maybe your generation, but not my generation. Because still, you can't break that 50-50.
Yeah.
Who knows why some people, and even if you try to do it with kids are better than grown-up adults, but if you look at all the studies, there's no rhyme or reason. You actually don't know why some people tolerate it, some people don't.
Right.
The only patient that I had that I saw and that I followed that tolerated and they took the patient off the immunosuppression was actually a girl with alpha-1 antitrypsin that got a living donor from the mom. So, I don't, obviously there's genetics and HLA matching,
Yeah.
I don't think it's even that, because it doesn't matter if it's living donor or deceased. There isn't a correlation. So I really still don't think we know what the characteristics are that leads to tolerance.
Histologically, we can't really identify either, right? Because I have a post-transplant patient, like 20 plus years for Hep B. He takes his cyclosporin rarely. He showed up after like 5 years of not following up, and his Alphonse was high, so I biopsied him and it showed chronic rejection. But he had not taken his meds in like several years. I tried to get him back on just cyclosporin 25 twice a day, and he shows up once every few years. Still, maybe actually no. Now he shows up like maybe once a year, and it's still like I take it like when I remember to.
Yeah, we don't have those stories, so obviously it's possible, but we don't know who they are.
What I think is just interesting is that his biopsy was not normal, but his disease has not progressed despite not taking cyclosporin. The biopsy showed chronic rejection, and he still barely takes it. His cyclosporin level is always undetectable in the rare times I'm able to get labs, but there's no progression. So I don't understand like what the histological correlation is between him being somewhat immunotolerant or even I don't know if you can call him immunotolerant if you're seeing rejection on biopsy, but he hasn't had any disease progression.
That goes back to what you were saying before, though. I
Pure
think.
sense of being immunotolerant is that you do a biopsy is completely normal.
Right, that's what I was saying.
That's your ultimate goal. I'm
No,
sorry.
I was just gonna say, that goes back to what you were saying before about, biochemically, these people look totally normal, and then you do a biopsy, and then it's chronic rejection. So.
But it's interesting, they say they could predict in 12 out of 14, based on the gene profile of the baseline biopsy. I think that, as you say, I think that could be part of the itching process. That seems promising to me.
Yeah.
But they really are. There is an ability. Barbara Murphy does this.
Yeah.
She did genetic expression where she could predict which patients will reject before it happens.
Yeah, that's what they say.
So we're there, but that doesn't still give you the key to tolerance. You can predict rejection, you don't have the key yet to whether to build tolerance.
Yeah. When they say they predicted tolerance was just that they could tell maybe who may reject or who may not kind of thing versus who may actually.
It's all different.
So when they say they could predict in 12 out of, so presumably you're scoring non-tolerant, tolerant. So I interpret that 12 out of 14 to say that 12 out of 14, based on the baseline biopsy, they could predict whether the outcome was going to be tolerant or non-tolerant as they defined it in the study. Is that correct?
Yeah, predicting rejection, I guess, is what's.
Rejection,
Yeah.
not tolerance.
Yeah.
But
You
this
can
is
predict
1
rejection,
year.
but not tolerance.
Yeah.
1 year
Yeah.
is not long.
Yeah.
Why did they exclude the autoimmune and viral patients?
Right.
Both are-
So I think there have been studies that show that these patients who have autoimmune liver diseases, they just have a higher susceptibility for rejection, I think, in general, and perhaps their tolerance or their tolerogenesis is not as great, and if anything may cloud their study
So
too.
it's not a problem with the immune profile.
What do you mean by that?
Autoimmune, the gene profile
Right.
expression might be affected by viruses.
Certainly can,
Autoimmune.
yeah. Sorry, I mean that's part of the reason why they excluded it. I think.
Because
Yeah.
there was a study of trying to wean people with active hepatitis C off immunosuppressive drugs, and they found no difference in the ability to wean people off immunosuppressive drugs, whether or not they had active hepatitis C. So I think it might be what Joe's talking about, that these metrics that they're trying to use would be so exotic if you had an active hepatitis C infection. I think it'd be hard to get a consistent immunological readout.
Yeah, and I would figure, especially with viral hepatitis, I'm sure the PBMC profile is completely different from someone who's
And the liver biopsy.
Right. All right.
Thanks, Brian.
Thanks.